Hello everyone. In today's session, we will learn about a case study on stress incontinence. This is our 16th gynecology case. Subjective data. So, this is a 49-year-old female. She had complaints of leaking of urine. This started after the birth of her third child 10 years ago and has gradually worsened. And she has not felt comfortable talking to her general practitioner about it until now. The leakage occurs on coughing and laughing, and she has recently started to play certain sports to lose weight, and the symptoms are much worse. So she has to use either a sanitary pad or incontinence pads to avoid leaking. Social history: she smokes 15 cigarettes per day and does not drink alcohol. She has three children. All the three children weigh 3.6 kg, 3.8 kg, and 4.1 kg respectively. And she needed a forceps delivery for the third child after failure to progress in the third stage. She has a regular menstrual cycle and has had a laparoscopic sterilization. There is no other relevant medical history, and she takes no medications. And there is no dysuria, nocturia, frequency, or urgency observed in the patient, and she is mildly constipated. Objective data: on examination, her body mass index is 29 kg per meter square, which is higher. There are no significant findings on abdominal or vaginal examination. And on further investigations, urine analysis was performed where protein, blood, leukocytes, nitrites were all found negative. And on her neurodynamics report, the first urge to void was felt at 300 milliliter. The maximum bladder capacity was 450 ml. Involuntary loss of urine was noted with coughing during bladder filling in the absence of detrusor activity. So, in a normal person, if a urodynamics report is performed, the maximum the capacity is approximately 500 milliliter, and even in that case the person feels full, but they can still control. But in this patient, the first urge was felt at 300 milliliter, so this can prove that the patient was maybe suffering from incontinence. Assessment: the diagnosis was made to be stress incontinence. Stress incontinence can be diagnosed from the history: involuntary loss of urine when the intra-abdominal pressure increases, such as with exercise or coughing. Signs and symptoms for this condition is leakage of urine while coughing, sneezing, laughing, lifting heavy weights, exercising, etc. So, in short, urine leakage is observed in case of any intra-abdominal pressure, which is also known as stress. The stress in this condition is usually, this term is used to explain the pressure that is exerted on the bladder. The need of therapy in this patient is to provide symptomatic relief and to improve the patient's quality of life. About this condition, so urodynamic stress incontinence, which was formerly referred to as genuine stress incontinence, is the involuntary loss of urine when the intravesical pressure exceeds the maximum urethral pressure in the absence of a detrusor contraction and can only be diagnosed after urodynamic testing. So intravesical pressure is the pressure exerted by bladder, and it is the pressure that is observed in the bladder when this pressure exceeds the maximum urethral pressure, which is the pressure in the sphincters of mid-urethral region. So if the pressure in the bladder exceeds the pressure in the urethra, the urine will flow out. So this is known as urodynamic stress incontinence, and this is usually diagnosed after urodynamic testing, which was also performed in this patient. The urethra is normally supported by fascia and muscles of the pelvic floor. If this support is insufficient due to any reason, the urethra would not close properly at times of increased abdominal pressure, allowing urine to pass involuntary. In women, pregnancy, childbirth, obesity, and menopause often contribute to stress incontinence by causing weakness to the pelvic floor or damaging the urethral sphincter, leading to its inadequate closure and hence the leakage of urine. So, these are the etiologic factors observed, especially in women, which is pregnancy and childbirth, obesity, and menopause. These conditions may cause weakness to the pelvic floor muscles, which results in involuntary flow of urine. In males, this condition is also observed in males, but it might be due to a prostate surgery or some drug induced incontinence. Stress incontinence can worsen during the week before the menstrual period. At that time, lowered estrogen levels may lead to lower muscular pressure around the urethra, increasing chances of leakage. And this incidence of incontinence also increases following menopause, and this is due to a similar reason, that is lowered estrogen levels. In female high level athletes, effort incontinence may occur in any sports involving abrupt, repeated increases in intra abdominal pressure that may exceed perineal flow resistance. In athletes, in a lot of sports, we can see repeated intra abdominal pressure that is exerted on a female. So, this might also cause weakening of the pelvic floor muscles and further lead to incontinence. Let's learn about the management and intervention, how to manage this condition. So, the conservative management is to make lifestyle changes. The women should be advised to control factors that exacerbate symptoms. So, the patient should try to reduce weight, and since she smokes approx 15 cigarettes, she should stop smoking to relieve chronic cough symptoms. Because in this patient on coughing, urinary incontinence is seen, there is flow of urine, so patient should try to stop smoking. Alter diet and consider laxatives to avoid constipation. The patient had mild constipation as one of her complaints, so laxatives could be used. Pelvic floor exercises, properly taught pelvic floor muscle training is very effective treatment and can cause improvement in symptoms or cure in up to 85% of women. So these exercises, there is also a type of exercise called the Kegel exercise. It is the repeatedly contracting and relaxing of the muscles that form part of the pelvic floor. So in these type of patients, patients should at least perform 24 daily contractions for up to 6 weeks to notice changes and improvement in this condition. The patient can also go opt for bladder training, which is also similar to pelvic floor exercise. In bladder training, the patient tries to void their bladder in longer intervals. This results in improvement in the involuntary flow of urine. Surgical management, the two main surgical techniques used currently are transvaginal or transobturator vaginal tape. In this, polypropylene tape is placed under the outlet of bladder, and colposuspension. Colposuspension, it is a procedure where the paravaginal fascia is attached to the Cooper's ligament. So this fascia is attached to the Cooper's ligament, which might result in more space for the urinary bladder. So that would help to fill more urine inside the bladder to collect more urine, so that it would result in less intravesical pressure and less involuntary flow of urine. Both are effective, but the former technique is minimally invasive and recovery is therefore more rapid. Alternative techniques such as periurethral bulking injections can be used in refractory cases or where the woman is unsuitable for surgery. The periurethral bulking injections are in this bulking agents are injected into the mucosa surrounding the bladder, neck, and proximal urethra. So this results in a decreased diameter of the urethra, and thus the urine would it would be difficult for the urine to involuntarily flow out if the diameter is low, and the urine would rather fill up more in the bladder, and this would result in longer intervals of void. So that's it for today's session. Thank you for watching, and please share this video. Thank you.